so much. So, we want this series to have significant content. One of the premises of the Institute and the Fellows is that we've all got a lot of great things to talk about. So, one at a time, let's hear from those people, and Mark is kindly leading us off. Within healthcare, patient safety is such a strong issue. Mark's work positions him so well as the idea person, not the, but in the idea generation area for a significant association with significant educational institutions. So very well prepared to speak to us. And Mark, I'll let you carry on from here. And I think we all look forward to hearing what you present. Thank you. And you can share your screen now, I believe. There we go.
Well, thank you. Thanks especially for this opportunity, and thanks to all of you for your attendance and attention today. Roland, you'll let me know if you're having any trouble hearing or seeing anything, please. And great.
All good.
Uh, this was such an first of all, I'm honored to be a member of this group. I look forward to our exchange of ideas, and I look forward to your critiques of this information today. This was such a timely request. As I said, I work for the American Association of Colleges of Osteopathic Medicine. There are 43 colleges of osteopathic medicine in the US. There are no international osteopathic colleges that train physicians at this point. Osteopaths in Europe and in some other countries have a very limited scope that is generally involved with musculoskeletal manipulation and the treatment of pain. In the US, osteopathic physicians have the full range, the full scope of practice as their MD counterparts. And so it's quite different having a profession that has two different and very distinct roles depending on whether you are in the US or outside the US. And as osteopathic medicine grows, I think I said during my introduction that we train 25% of the physician workforce. By the time, 5 years from now, it'll be a third of the physician workforce because of the growth in osteopathic medical schools and in the seats in osteopathic medical schools. And so it certainly has engendered a lot of changes in our organization. One of those key changes is that our U.S. osteopathic medical schools are looking for clinical training sites outside the U.S. And so they asked me to do a little work because of my background in health policy and sort of the evaluation of healthcare. They asked me to do a little work on where osteopathic physicians might fit in to sort of what would be the easiest countries, I guess, for our students to adapt to for clinical training. So this presentation involves 10 countries that I didn't exactly pick at random, but I picked them to try and compare some very different healthcare systems. And I will say, I've been working in healthcare for almost 40 years now, and because I work with medical students and learners in residency and fellowship, I get to be one of those few lucky people who have hope that the best days of the healthcare system are ahead of it and not behind it. And I have to say that's quite a thing to believe, despite all evidence to the contrary. But I hope that you believe that too once we get to the end of this presentation. Osteopathic medicine and our osteopathic medical education has a particular focus on the patient experience. If you don't know what osteopathic medicine, osteopathic manipulative medicine is, it is a one-on-one, hands-on approach between the physician and the patient that uses musculoskeletal manipulation, as I described for our osteopath colleagues in Europe, to treat pain, but also to treat other other ailments and to augment other kinds of treatment. That gives our students a particular, I think, both relationship with their patients and reputation among their patients, just because of that connection of touch. The osteopathic philosophy contains four core components. The first is that the patient is a unity of body, mind, and spirit. The second is that the body has the innate capacity to heal and regulate itself. The third is that the body is structured in a specific way because that structure supports the body's function, hence the focus on musculoskeletal medicine. And finally, that patient care, rational treatment of patients should include all of those components. And so I think that we're sort of living in a golden age of osteopathic medicine, if you will, where none of us would argue that body, mind, spirit treatment is sort of the healthcare that we all desire, right? And we get it from MDs and DOs now because it's so widely accepted. We get it from those who are not physicians because it's so widely accepted. You know, the body's innate capacity to heal itself. When A.T. Still, the founder of osteopathic medicine, developed that statement in the early 1860s, there was no knowledge of the immune system, and yet we all know the importance of prevention and vaccines and the immune system, and those have certainly come back into the conversations that we're having about healthcare and health outcomes. And finally, you know, the relationship between structure and function and providing alternatives to prescribed opioids and other kinds of pain treatment has become sort of de rigueur now for physicians, regardless whether they're MDs or DOs. And so our students, I think, are made aware early on of the importance of the patient experience for healthcare quality and improved outcomes. Better experiences mean that you will get better faster. It means that you are less likely to go to the emergency room. It means that you are more likely to participate and cooperate and adhere to your treatment and therefore be healthier. And so, as you can see, these are all very well researched and well evidenced impacts of the relationship between the patient and the physician controlling for all other healthcare variables, right? So these outcomes are available to you simply through an improved relationship, improved engagement with your healthcare provider, whether they're a physician or a non-physician healthcare provider. These have been researched and analyzed across the gamut of health professionals and across a wide range of patient illnesses and symptoms. Particularly, I want you to pay attention to utilization or access, and especially lower error rates. That'll come back when we're talking about some specific country healthcare systems. There's a lot of conversation about the quality of the U.S. healthcare experience, and particularly the lack of value when you compare the spending on healthcare in the US with the outcomes of healthcare in the US. And we certainly have a system that has a lot of transactions in the system. There's a lot of component pieces to our system, more than in other countries. I will argue today, though, that they're not all negative, and we have some specific patient engagement across the healthcare system that makes us different in a couple very specific ways from other healthcare systems. In the US, the main quality measure used by MD physicians, DO physicians, hospitals, healthcare institutions are what is now called the quintuple aim. It started out as the triple aim, improving health outcomes, enhancing the patient experience or patient satisfaction, and reducing costs. About 3 years ago, improving provider well-being was added to the three cost, quality, and patient experience access guidelines. And then 2 years ago, advancing health equity across communities was added to the guidelines as well. So we now have a quintuple, a five-piece framework that we use in the US. Most of the rest of the world uses these World Health Organization quality measures: effectiveness, timeliness, safety, equity, people-centeredness, and integration, or the connection and collaboration of different treatments across the health system. The WHO is looking at adding resilience, and there's been a lot of evidence and a lot of measures of how resilient is your healthcare system. So how can it handle changes in community health? How can it handle disasters? How can it handle advances in medicine and in patient treatment? So pretty similar, honestly, an emphasis on quality patient experience, which includes access in both the US and the WHO frameworks, the importance of equity and the prioritization of safety. In the US, more of a concern about cost and cost efficiency, and adding the provider well-being that was added a few years ago. So I picked 10 countries based on resources and differences between their healthcare systems. And honestly, because of the opportunities that I had to work with some of the Mandela Fellows last summer who were from Africa. And so I learned a lot about the Nigerian healthcare system last summer, and so included that in this analysis. And so there's easy to defend the inclusion of some of these healthcare systems. The U.S. Very high resources spent on healthcare, predominantly private, but sort of looked at as in some ways a model for medical innovation and the advancement of new treatments. Canadian, a single payer system that emphasizes equitable access. German, a high income social insurance model. So very similar to the if you carried out the Affordable Care Act to its logical conclusion, you would end up with something that looked a lot like the German healthcare system. UK, the National Health Service, has a lot of supporters across the globe. Brazil is a sort of a middle income country and a country whose population and whose GDP are growing, and they're spending a lot of that on healthcare. India, South Africa, and I don't know why Nigeria is not showing up on my screen, but Nigeria is a low resource country with a relatively high population that has recently undertaken some far-reaching healthcare improvements. And I will say India the same. So we're going to talk a little bit about that as well. So I wanted to include, high, middle, and low income countries with diverse health delivery models, robust patient experience data like the US, UK, and Germany, and where there's not as much patient experience data, but the data that there is illustrates some real gaps in both access and in patient engagement with their physician, with their provider, with their treatment. So I go through and just highlight a couple specific things for each country. The US suffers from much higher rates of medical errors compared to other high-income healthcare systems. And it has a great deal, and these two things are related, has a great deal of care fragmentation. If you've ever gotten care in a US hospital, you know that When your doctor orders an X-ray, someone comes to your room, rolls you down to the radiology department, and you get the X-ray. When you're being seen as an outpatient, which is what 80% of the patients in the US are seen as, your doctor prescribes an X-ray, and you have to figure out how to get the X-ray and how to pay for it and how to travel to it and all those kinds of things. And it's a very disjointed and fragmented kind of system. Additionally, we have the highest administrative costs in the world. So the UK, I think that what people understand about the UK is that it is a very integrated healthcare system that attempts to provide comprehensive care for all of its patients. A common flaw of of all these kinds of systems in high income countries, longer wait times, and patients generally don't feel as involved in their care as they do in the US. And there's not a good measure for patient engagement, so I've subbed in patient literacy, healthcare literacy, which we'll talk about at the end. So what is your patient's understanding of the healthcare system? That's not the best proxy in the world, but it does represent something about the patient's involvement in their healthcare. Germany, very well known for high quality services and outcomes where patients can choose their providers with a social insurance model that tries to promote equity. The sort of knock on the German healthcare system is that it is slow to innovate and slow to adopt advances in healthcare. Canada, and I understand I'm talking to some Canadians, and I appreciate your criticism and your feedback when we talk about the Canadian healthcare system. Quality measures in Canada are very high. Patient safety measures in Canada are very good. Generally universal coverage, although if you look at the First Nations experience of access to healthcare, you will find it is not great. And wait times in Canada, especially for specialist care, have resulted in the growth of sort of private healthcare in Canada that's outside of the Canadian healthcare system for those who can afford to pay. So Brazil, a middle-income country that is growing quickly and spending a lot more money on healthcare. The access to care and the quality of care varies widely across the country. The care that you get in rural areas or coastal areas is very different than the care that you are able to get in the interior of the country. Community health is a big push in Brazil now. But quite frankly, it's not getting the results that I think the Brazilian public health and other healthcare workers wish it would. Universal access is what Brazil is supposed to have, and yet there are many, many people in Brazil without access to healthcare. South Africa, our first African country. Again, there's a public. South Africa is very interesting because it has a public-private system with a lot of disparities between those two systems. And so, if you are using the public system, which most of the population does, your access to care, the safety of that care, and the quality of that care vary widely from the care that those in the private system get. And the private system, of course, because it's better medicine attracts the better healthcare providers. And so the better trained healthcare providers are often in the private healthcare system and not available to those who use the public healthcare system. India, excuse me, recently started a real community health push that we'll talk about a little bit more towards the end, but lots of emphasis on access to care and the patient experience. Again, a mix of public and private providers, where the private is very high quality care but remains inaccessible to most people in India. The difference in India is this community health initiative that they've recently taken up. Chinese healthcare also is in the midst of a big reform, and trying to increase the focus on patients, but patients, rather than longer wait times, they have much shorter visits, or visits with individuals who are not considered to be at the proper level to provide them the care they need. So as depending on where you are getting your care, you are either waiting in sort of an industrial factory-like line to get fed through the system if you're in an urban area, or you have access to some level of primary care in rural areas, but very rarely access to specialty care. Australia, certainly, like Germany, one of the models of a healthcare system, high quality outcomes, especially in cancer care and in managing people with chronic diseases. Again, the knock on these high income, high quality care systems is waiting for specialist appointments because, rightfully so, the focus on primary care improves health outcomes for most people. And there are a lot of patient engagement incentives and initiatives in Australia that the US could do and others could do well to learn from. So Nigeria, which I'm sorry was not on my previous slide, is a low-income country that has really challenging delivery problems, both because of differences in rural and urban care, but particularly because of the consistent long-term influx of refugees. And so the refugees are sort of um, members of the country, are in the country, but don't get the same health care as citizens of the country. And so overcrowding and underfunding really limit what they can do for their patients in Nigeria. Significant disparities with rural areas and refugee populations disproportionately affected by lack of access, reliance on out-of-pocket cash payments, which of course lend themselves to corruption. All right, as I said, I'm a methodologist, which means I need to show you numbers. And so my team, my research team, and I developed this little radar chart that you see in the upper left corner there. We took some of the key measures, health literacy as a proxy, as I said, for patient engagement, patient autonomy, how much decision-making power does the patient have in the healthcare system, social determinants of health, health disparities, quality, access, and cost. And we sort of mapped, good versus bad. The more towards the outside of the circle you are in that area, the better the country does in that area. And I think that this is a more effective way of looking at countries than saying things like, US has bad outcomes compared to how much money it spends, right? You want to know more about the why. And the why is because we have very high costs. We have limited access to all of our services because of those costs. And we have a great deal of differences between racial, ethnic, and rural populations. And frankly, gendered populations as well. So that's sort of where we're high and low on this chart. So the system complexity can be overwhelming. Disparities are often based on your socioeconomic status, but very advanced medical technology and treatment, a great deal of choice in providers and facilities, and a focus on patient care. Even though it says, especially in private healthcare, I honestly might take that out if I were redoing this slide because Medicare and Medicaid patients have a wide choice as well. I know we hear that especially Medicaid patients have trouble finding physicians, but if you look at that as a global phenomenon, Medicaid patients still have a great deal of choice as well. So here's our little map for Canada, our little radar chart for Canada. I hope you find these interesting. I was trying to make this sort of how can we compare these countries together? So long wait times for specialists and elective care, geographic challenges, especially for First Nations peoples and others, limited availability of private options, but it feels equitable without financial variables, sometimes distance variables, sometimes other kinds of barriers, but it feels equitable. Strong primary care, lots of preventive care, and access to all necessary services, even though there's a wait time. Germany, as you can see, looks pretty good on a lot of these measures. Germany is a more recently diverse country and still hasn't quite managed that into its healthcare system, so it doesn't score great on health disparities between racial or ethnic groups or other groups. But still a pretty great content in terms of the freedom to choose, in terms of the quality, right? The UK, the NHS is something that we've all heard of, and it sort of gets okay scores in many areas. Again, not great scores in managing health disparities, strong focus on public health and prevention, lowest cost of any of these countries that you're going to see. Um, Once again, Brazil has very strong community health initiatives and access to essential services and medications, which is rare for a low or middle income country. But again, long wait times and overcrowding. South Africa, as you can see by the chart, doesn't do very well compared to many of these other systems because of they sort of have all the big negatives, significant disparities between public and private systems, overcrowded, under-resourced public systems, and long wait times for both private and public systems. India's community health initiatives have started to pay off. So even though many of the higher income folks choose to use the private system in India, the public system does provide affordable care to many Indians without attention to their ability to pay, and their healthcare program, Ayushman Bharat, has really shown real advances in the quality of care for all the folks in India. China, if you can get care, it is of very high quality, but overcrowding and limited access to specialists in rural areas mean that there's a lot of folks who are not going to get access to that care. Australia is really good in most areas and really needs to work on the disparities between its indigenous populations and its minority populations and the majority populations in Australia. So they have universal healthcare access, but the ability to actually get in and receive care, if you are in one of the indigenous areas or if you're in a rural area, is usually not there. And if you need to see a specialist, you can afford to do so, you frequently switch to private insurance.
Mark, please pardon, but just minding the clock.
Yep,
If you
this
if you
is
could
my
navigate
third from last slide. So we're
navigate to the end, and so we can
yep,
open for conversation. Thank you.
yep. So again, Nigeria does fairly poorly on most of these measures, as you might expect from such a low-resourced system. But their new efforts in getting community-based healthcare to everyone without regard to ability to pay has allow them to start improving maternal and child health outcomes. So here's the big picture when you can sort of see. I think this tells you a little bit more about how the US does compared to other countries and where, if you're moving somewhere for healthcare, where you might want to move to, right? So probably Germany, Australia, right? So anyway, I hope that you find this an interesting way to compare these countries because it hasn't really been done before, and I really enjoyed doing it for this session. I think that one of the things that this should lead you to conclude is that we, regardless the country, regardless the system, regardless the resources, we have a lot of common problems. And doesn't it make sense to collaborate, to cooperate, to work across borders to solve the many, many common problems we have in reducing disparities in care, in improving health literacy, in recognizing issues with social determinants of health, and in patient engagement. So that's what I wanted to communicate today, is that there's a great deal of similarity in what patients want and expect from their healthcare system. And there's a great deal of shared hope and also disappointment. And it's probably easier to address some of these problems if we cooperate and collaborate to improve patient experiences worldwide. So I hope that you found that comparison interesting, and I look forward to your critiques.